Imagine a house with pristine paint and perfectly smooth drywall. Visually, everything looks completely structurally sound.
Right, but behind those walls, termites have entirely hollowed out the wooden support beams.
Exactly. The outside looks totally fine, but the destruction is already complete. One heavy touch, and the whole wall just collapses.
And right now, in intensive care units and, nursing homes around the world, this exact phenomenon is happening inside the human body.
Welcome to today's deep dive. I'm your host, and whether you're a nursing student studying for boards or just someone who's intensely curious about the hidden mechanics of human health, today's deep dive is custom built for you.
And I am your resident expert, here to help break down the science. We are looking at a medical condition today that is incredibly common, fundamentally misunderstood, and frankly, potentially deadly if it goes unchecked.
We are unpacking the science of pressure injuries today. We're going to look at the physical forces that literally crush cells to death, the intense controversies around how to stop it, and why the established medical vocabulary you might be familiar with has completely shifted.
It's a huge topic, yeah. There's a lot of history and physiology to get through.
Okay, let's unpack this, because right out of the gate, we have to talk about the name. If you're outside the medical field, you probably know this condition as a bedsore or maybe a pressure ulcer.
Right, which are terms that everyone uses, but they are actually entirely outdated now.
And the reason for that is wild. So the word bedsore is gone, and even pressure ulcer has been quietly retired.
Yeah, the shift in vocabulary is actually the key to understanding how the damage happens in the first place. In April 2016, the U.S. National Pressure Ulcer Advisory Panel held this big consensus conference, and they officially dropped the word ulcer in favor of injury. They also modernized the staging system, so they swapped out the old Roman numerals for Arabic numerals, like just 1, 2, 3, 4.
I can hear people rolling their eyes thinking, this is just some minor housekeeping thing for a medical dictionary. Just semantics.
Oh, it's so much more than semantics. What's fascinating here is that, by definition, an ulcer implies an open wound.
Right. It means there is a physical break in the skin.
Exactly. So calling it an ulcer when the skin isn't even broken is a massive contradiction. And that contradiction basically forced nurses into a corner for decades.
Because they were seeing damage where the skin was perfectly intact, right?
Yes. The medical community realized that some of the earliest stages of this condition, and frankly, some of its absolute most dangerous forms, happen when the skin is completely intact.
Wow.
So the term injury covers the entire spectrum. It includes that intact, discolored skin all the way down to a deep crater that exposes bone. And it does that without falsely implying that every single stage has to be an open sore.
And they were so serious about this, right, that in 2019, the organization actually renamed itself to the National Pressure Injury Advisory Panel, or NPIAP, just to reflect this new reality.
They did, yeah. It was a huge paradigm shift.
Which brings us right back to that termite analogy from the beginning. In the source material, there is a specific classification called a deep tissue pressure injury, or a DTPI.
Ah, yes, the DTPI.
People think a dark red or purple patch of intact skin is just a bruise.
And that assumption is incredibly dangerous. A deep tissue pressure injury represents damage that has already been done deep down in the muscle and the fat layers, right next to the bone.
So it's not starting at the surface at all?
Not at all. The damage happens from the inside out. Bone is hard, and the mattress is hard. The tissue trapped in between takes the absolute brunt of the force.
Oh, I see.
So by the time you actually see that purple or maroon discoloration on the surface of the skin, the underlying tissue has already suffocated and died.
So the collapse is pretty much inevitable at that point. You're basically just waiting for the surface to give way.
Unfortunately, yeah. Because the structural damage is already done, a DTPI can just burst open into a massive, full-thickness wound within a matter of days.
And when we say full thickness, we mean a wound that is burned through the outer epidermis, through the dermis, and down into the subcutaneous fat or even muscle.
Right. And it can happen rapidly, even if the patient is receiving meticulous, perfect care from the exact moment that purple spot is discovered.
That hidden damage completely reframes who we think is at risk, doesn't it? Because we always picture someone bedbound, just lying in a hospital bed all day.
Oh, definitely. But the 2016 conference also added a category specifically for medical device-related pressure injury.
Right, which totally shatters the myth that this is solely a bedsore problem.
Exactly. I mean, seated patients get them over their sitting bones. Surgical patients get them just from lying on a rigid operating table during a really long procedure.
And crucially, Everyday medical devices cause them too.
Hmm.
Think about the rigid plastic of oxygen tubing wrapped really tightly behind the ears.
Or a stiff cervical collar around the neck, or even just a plaster cast.
Right. If that plastic presses against the skin for even a couple of hours, it is compressing the blood vessels in the exact same way a mattress compresses a tailbone.
It's the exact same mechanism, yes.
So let's get into the actual physics of that. We really need to look at the mechanical forces that are actively destroying these cells.
Well, if we strip away all the clinical vocabulary, we're basically left with straightforward physiology. Your capillaries, those microscopic blood vessels that feed oxygen to your tissues, they require a certain minimum internal pressure to stay open.
Okay, that makes sense.
So when you push down on the skin over a bony prominence, you are applying external pressure. If that external pressure from, say, the bed frame or the oxygen tubing is stronger than the internal pressure of the blood vessel, the blood flow simply stops.
It's like stepping on a garden hose. The water just can't get through.
That's a perfect way to look at it. And when blood flow stops, oxygen stops. That creates a state of hypoxia.
And without oxygen, the cells in that area just begin to die off, right?
Yeah. Exactly, which we call necrosis. Now, a healthy person who is shifting in their sleep, they don't get these injuries because their nervous system sends a discomfort signal.
You just roll over without even waking up.
Right. The pressure is relieved and the blood rushes right back. But a patient with reduced sensation or mobility, maybe from a spinal cord injury or heavy sedation in an ICU, they never get that signal to move.
So we're essentially looking at three distinct physical forces at play here based on the research. There's pressure, shear, and friction.
Yes, the big three.
So pressure is that perpendicular force crushing the tissue against the bone, like we just described with the garden hose. Friction is surface abrasion, like skin dragging across a rough hospital sheet.
And friction doesn't usually cause the deep internal injury on its own, but it strips away the protective outer layer of the skin, which makes it super vulnerable.
But I want to zero in on shear,
Yeah.
because the source text had a really fascinating example.
Shear is arguably the most insidious of the three forces, for sure, because it happens entirely beneath the surface.
The mechanics of it are wild. It's an angular force. So imagine a patient lying in a hospital bed, and the head of the bed is raised up so they can watch TV or eat their lunch.
Okay, a very common scenario.
Gravity naturally makes the patient's heavy skeleton want to slide down toward the foot of the bed. But friction is keeping their skin firmly anchored to the bed sheet.
Right?
So the skin stays put, but the bones and the deep tissues slide downward inside the body. It essentially stretches and kinks all the perforator blood vessels trapped between the bone and the skin. Is that why nurses are taught the strict rule to keep the head of the bed at 30 degrees or lower?
That is exactly why. You're creating an internal scissor effect that just tears those vessels from an angle.
Oh, wow.
Keeping the head of the bed low minimizes that downward gravitational pull. It physically limits the skeleton's ability to slide inside the skin, which protects those fragile blood vessels from being sheared and basically choked off.
Okay, so we understand the physics of the crush and the tear, but how much pressure does it actually take to cause this? Because this is where human intuition and honestly medical history kind of totally fails us.
Oh, the historical benchmarks are wild.
Right. For generations, nursing textbooks taught a very specific threshold,
Yeah.
32 millimeters of mercury. That was supposedly the exact pressure that closed the capillary.
The famous 1930 physiology study by Eugene Landis, it became an absolute pillar of nursing education.
But here's where it gets really interesting. I mean, Landis measured this in the healthy fingernails of young people.
Yes, he did.
How on earth did a localized measurement from a healthy 20-year-old's fingernail in 1930 become the unquestioned gold standard for treating the sacrum of a frail 84-year-old ICU patient?
It is one of those fascinating quirks of medical history, where a single flawed data point just becomes gospel through sheer repetition.
It's crazy.
Modern science has completely reevaluated that. We now treat that 32 millimeters of mercury as a very rough historical benchmark, not a hard universal threshold.
So what's the actual metric then?
Well, actual tissue tolerance varies wildly depending on the anatomical location, the patient's overall blood flow, their disease state, and crucially, the element of time.
Right, time is the other half of the equation.
In 1959, a physician named Dr. Marian Kosiak conducted experiments proving that tissue damage is about the dynamic interaction of magnitude and time.
So it's like a curve.
Exactly. It's a pressure time curve. A very high pressure applied for just a brief moment might be completely harmless. But a comparatively low pressure, well below that 32 millimeters of mercury, if it's sustained for hours, it can completely destroy the tissue.
So if time is just as much of an enemy as the raw pressure itself, then the obsession with turning patients makes total sense. You hear it constantly in healthcare. Turn the patient every 2 hours.
The QH rule, yes.
It has been treated like scripture. But I'm looking at this major NIH-funded study from 2013, the TURN study, led by Nancy Bergstrom. And turning them every 2 hours didn't actually solve the problem, did it?
It genuinely shocked a lot of people in the field. They took patients in nursing homes, placed them on high-density foam mattresses, and compared repositioning them every 2 hours, every 3 hours, or every 4 hours.
And the results?
There was absolutely no meaningful difference in the incidence of pressure injuries between the three groups.
Wait, really? So the 2-hour rule was just arbitrary?
It proved that the rigid, universal rule wasn't as absolute as everyone assumed, provided you have the right technology underneath the patient.
The support surfaces?
Right. High-density foam mattresses work by redistributing the patient's weight over a much larger surface area. Instead of all the mechanical force being point-loaded onto just the tailbone or the heels, the foam contours and spreads that pressure out.
So when you change the physics of the surface, you change the math on how quickly the tissue dies.
Exactly.
But if the 2-hour rule isn't an absolute shield, and foam mattresses really just buy us time, we hit a massive philosophical wall here. If nurses do everything right, if they follow the protocols perfectly, are these injuries always preventable?
That is the million-dollar question, and it remains highly, highly debated today.
We have to look all the way back to Florence Nightingale to understand why, don't we? In her 1859 book, Notes on Nursing, she famously wrote that if a patient develops a bedsore, it is generally not the fault of the disease, but of the nursing.
Right. She basically invented the idea of a nursing-sensitive outcome.
But she also planted a seed that grew into a century-long belief that every single injury equals a failure in care.
And that underlying idea heavily influenced the modern quality improvement campaigns we saw in the 2000s and 2010s.
Yeah.
There were massive administrative pushes for, like, target zero hospital environments.
Right.
The message was clear. Every pressure injury is a lapse in nursing vigilance. You basically just need to try harder.
But human biology isn't a spreadsheet. The bedside reality pushed back hard against that narrative, didn't it?
It really did, because the target zero message just constantly collides with the biological reality of critically ill and dying patients. This is where we really have to discuss the Kennedy terminal ulcer, which was first described by a nurse named Karen Lou Kennedy Evans back in 1989.
What exactly did she find?
Well, she observed a very specific, undeniable pattern in dying patients. They would develop a pear-shaped or sometimes a butterfly-shaped area of rapid skin breakdown, usually right over the sacrum.
And this wasn't from neglect?
No, it would appear suddenly, sometimes literally in a matter of hours, and progress incredibly fast, despite the nurses providing absolutely meticulous care.
So what is the biological mechanism there? How does the skin just give up like that?
If we connect this to the bigger picture, it introduced the clinical concept of skin failure. This is now captured in consensus statements like SCALE, which stands for Skin Changes at Life's End.
Okay, skin failure.
Think about the physiological process of a human body shutting down. As blood pressure drops and oxygen levels fall, the autonomic nervous system goes into survival mode.
It's trying to save the core, right?
Exactly. It triggers massive vasoconstriction, basically clamping down the blood vessels in the extremities and the skin, just to shunt whatever oxygen is left to the vital internal organs, the heart, the lungs, the brain.
So the body is actively sacrificing the skin to keep the brain alive.
Exactly. And the skin is the largest organ in the body. We readily accept that the kidneys can fail at the end of life. We accept that the lungs can fail.
But we expect the skin to be invincible.
Right, but the skin fails too. Therefore, not every pressure injury is a lapse in care. Sometimes it is just the unavoidable biological process of dying.
But the stakes of this debate aren't just academic or emotional. They are incredibly financial. In 2008, the Centers for Medicare and Medicaid Services made a massive policy change.
Oh, the CMS rule, yes.
They added hospital-acquired stage 3 and stage 4 pressure injuries to their list of reasonably preventable conditions. Basically, they said, if a patient gets one of these severe injuries while in your hospital, we are no longer paying you the extra cost to treat it.
It was an absolute earthquake in hospital administration. It essentially turned a clinical problem into a massive billable cost problem overnight.
Wow.
Suddenly, hospitals had intense financial motivation to fund skin assessment programs, invest in those expensive high-density support surfaces we mentioned, and strictly enforce documentation.
It also meant they had to rely heavily on standardized risk assessment tools, right?
Okay.
You mentioned Nancy Bergstrom earlier with the Turn study. Back in 1987, she and Barbara Braden created the Braden scale.
Yes.
And before that, a British nurse researcher named Doreen Norton developed the Norton scale in 1962.
Right. And the Braden scale is still the most widely used risk screen in the world today. It scores patients on 6 specific subscales: sensory perception, moisture, activity, mobility, nutrition, and friction or shear.
And interestingly, a lower score means a higher risk.
Yeah.
Okay.
Exactly.
Let's pause on those subscales for a second.
Yep.
Immobility and friction make obvious sense based on the physics we talked about earlier. But how does moisture or a bad diet physically accelerate a pressure injury?
It all comes down to cellular integrity. Prolonged moisture, whether that's from sweat, wound drainage, or incontinence, it alters the pH of the skin.
Okay.
It strips away the skin's slightly acidic protective mantle, which is a condition called maceration. The skin becomes waterlogged and incredibly fragile, kind of like when you stay in the bathtub way too long.
Right, it gets all pruny and soft.
Yeah, and then it tears with almost zero force. As for nutrition, the body requires massive amounts of protein to maintain and rebuild cell walls.
So if they aren't eating well?
If a patient is malnourished, they literally lack the physical building blocks required to repair the microscopic tissue damage that happens just during normal daily movement.
That makes it so clear why this isn't just a surface-level cosmetic issue.
Yeah.
You see how dangerous this is when you look at the tragic case of the actor Christopher Reeve.
Such a sad case, yes.
He was paralyzed in a horse riding accident in 1995. And years later, he developed a severe pressure ulcer. Because his sensation was impaired, he couldn't feel the early warning signs.
Right.
It became deeply infected, and he ultimately passed away from complications related to that systemic infection. It is a stark reminder that a pressure injury is a direct portal for life-threatening infections to enter the bloodstream.
Which is exactly why nurses on the floor today must assess, stage, and document these injuries with absolute precision. But I will say, there are some major traps and misconceptions when it comes to actually staging these wounds.
Yes, and this is where human intuition completely fails us again. The biggest exam-style takeaway here for you listening is this. Staging is not a trajectory. Injuries do not progress neatly from stage 1 to 2 to 3 to 4, and they absolutely do not heal backwards.
This is a very common point of confusion, even among seasoned healthcare workers. Staging only describes how deep the anatomical damage is at the exact moment you assess it.
Right.
So a wound can show up as a deep stage 4 immediately, with no prior warning signs on the surface whatsoever. And here's the really critical part. When a massive stage 4 wound heals, the body does not magically regenerate the missing muscle or subcutaneous fat.
So what actually takes its place?
It fills in with granulation tissue, which is that bumpy, pink, new connective tissue the body uses to patch holes, and eventually it becomes dense scar tissue.
But it's never the same tissue.
No.
Yeah.
Because the original anatomical layers of fat and muscle are gone forever, the structural integrity of that area is permanently altered. Therefore, it is always documented as a healing stage 4. You never, ever downstage it to a 3 or a 2 just because it gets smaller.
That makes total sense. If the muscle is gone, you can't just pretend it's a superficial stage 2 just because the hole is shrinking.
Exactly.
Then there's the trap of the unstageable wound. If I see a wound labeled unstageable, my brain immediately assumes it is so mild, or maybe so small, that it hasn't even hit the scale yet, right?
That is a very dangerous myth, and it's exactly the opposite of the truth. In this clinical context, unstageable means the wound bed is completely obscured by necrotic dead tissue, what we call slough or eschar.
What does that actually look like to a nurse assessing it?
Slough is essentially dead white blood cells and cellular debris just clumping together into this yellow, stringy mass. And eschar is when the dead tissue dries out into a hard, dark, leathery scab.
Okay, so it's acting like a lid.
Yes, exactly like a lid. Because that dead tissue is blocking your view, you literally cannot see the bottom of the wound to know how deep it goes. By NPIOP convention, you must assume an unstageable wound is at least a severe stage 3 or stage 4 until that dead tissue is surgically or chemically cleared away.
So hiding the depth never implies mildness.
Never.
We also have to separate pressure injuries from other types of skin breakdown that look super similar to the naked eye. The source material mentions terms like moisture-associated skin damage, or MASD, and specifically incontinence-associated dermatitis, or IAD?
Oh, these are frequently confused, especially when assessing the sacrum. The key here is understanding the direction of the damage.
What do you mean by direction?
Well, pressure injuries happen from the inside out or bottom up due to those crushed capillaries near the bone that we talk about. But IAD happens from the outside in or top down.
Ah, okay.
It is a surface level chemical irritation caused by the ammonia and the enzymes in urine and stool just breaking down the epidermis over time.
So a patient could have a red area on their tailbone, and it can be a bottom-up stage 1 pressure injury or a top-down IAD, or I guess a combination of both.
Exactly. But getting that diagnosis wrong alters the treatment protocol entirely. And because of that 2008 Medicare rule we mentioned, it drastically alters what the hospital is legally required to report and pay for.
So what does this all mean? When you put all this together, the physics of internal shear, the complex staging rules, the biological variables of the Braden scale, why is distinguishing all these nuances so critical on the floor today?
It matters right now because hospitals are facing just a perfect storm of challenges. We have a rapidly aging population entering the healthcare system with more complex, compounding diseases and vastly reduced mobility.
Right.
At the same time, there is a massive push in intensive care units for early mobility, getting ventilator patients moving sooner, specifically because fewer sedated, immobile patients means fewer pressure injuries.
But counteracting all of that is a severe, widespread hospital and nursing home staffing crisis. And doing this right requires serious manpower, doesn't it?
It really does. Consistent skin checks, applying barrier creams, and careful two-person turning to avoid friction and shear. These are incredibly labor-intensive tasks. When nurses are stretched thin, managing multiple critical patients, these physical, time-consuming preventative tasks are often the very first things forced to slip.
It is a profound systemic challenge. Thank you for going into the medical trenches with us to explore how this hidden damage actually works.
It was my pleasure. Thanks for having me.
We've covered the physics, the history, and the intense realities facing bedside care today. But I want to leave you with a final thought to mull over. Think back to the Kennedy terminal ulcer and that biological concept of skin failure we discussed. We readily accept that a heart or a lung can simply give out at the end of life, despite our absolute best medical efforts to save them. But because the skin is on the outside, because it is entirely visible to grieving families and to strict financial regulators, we have spent decades demanding that it be invincible. If we fully embrace the skin as an organ that is biologically allowed to fail at the end of life, how might that change the way we approach end-of-life care and the grace we give to the nurses providing it?